Chronic pancreatitis. So let's discuss the important MCQ points on chronic pancreatitis. The first question that is asked is regarding your causes. So there is the classification with respect to the causes which was given by your Whitcomb, known as the Tigaro classification. So what is the Tigaro classification? It is the causes of your chronic pancreatitis, where T stands for toxic or your metabolite causes, which include like alcohol, hypercalcemia and tobacco. Now alcohol is considered to be your most common cause of chronic pancreatitis. Then we have your idiopathic causes, which could be an early onset, late onset or your tropical form. Then G is for your genetic causes, which consist of your autosomal dominant when the mutation is in your PRSS1 gene, autosomal recessive when it is in SPINK1 gene, then it can be in CFTR defect or an alpha 1 antitrypsin deficiency. Then we have your autoimmune or immunologic causes, which include your viral infection like hepatitis B and Coxsackie virus, and autoimmune, which could be a primary autoimmune disorder or be associated with a Sjogren's syndrome. Then we have your recurrent and severe acute pancreatitis, which includes your vascular disease, ischemia and post-radiation therapy. And your obstructive mechanical causes includes your pancreas divisum, sphincter of Oddi dysfunction, annular pancreas, colodococele, malignant obstruction of the pancreatic duct and primary pancreatic duct stone. So regarding the pathogenesis of your chronic pancreatitis, there have been various theories proposed. So let's just take a look at the name of the theories and discuss one of the most important theories, which is your sentinel acute pancreatic event. So the various theories are your necrosis fibrosis theory, protein plug hypothesis, oxidative stress theory, then you have your toxic metabolite theory and your primary duct hypothesis. Now your sentinel acute pancreatic event, so what happens over here is that any genetic or other mechanism causes the critical sentinel event, which triggers the process of acute pancreatitis that eventually propagates to your chronic pancreatitis. Now the initiation of this sentinel event would also cause the activation of your immunological process and your stellate cells, which propagates chronic pancreatitis and leads to fibrosis and calcification. Right. Now pain is the most outstanding symptom of your chronic pancreatitis. Other clinical features would include your weight loss, malnutrition, exocrine insufficiency, endocrine insufficiency and extra pancreatic complications like your intestinal obstruction, biliary obstruction, GI hemorrhage and your hemocircus pancreaticus. Now for investigation, we see calcification in your CT scan. Then MRCP would give us a better anatomy regarding knowledge regarding your pancreatic duct. Then your IV secretin during MRCP is going to help us identify your pancreatic duct strictures, and regarding the anatomy of the duct, it would be given better by your ERCP. So we have this image over here, which is an image of an ERCP showing features of chronic pancreatitis. Now this is the classical features seen over here, which is like lake of chain appearance, right? So these are your dilated chain of lakes. This is one of the classical features of your chronic pancreatitis. Then regarding the medical treatment, so we have taken this summary box of your medical treatment from your Bailey and Love. So it includes your treat the addiction, that is to help the patient stop alcohol consumption and tobacco smoking, and involve a dependency counselor or psychologist. And then alleviate the abdominal pain, eliminate the obstructive factors like whether it is in duodenum, bile duct or pancreatic duct, escalate analgesia in a stepwise fashion, refer to a pain management specialist, and for intractable pain consider CT or endoscopic ultrasound guided celiac axis block. Right. So that pain management would be your stepwise pain management, and only in cases of intractable pain you would go for a celiac plexus block. Then you have your nutritional and pharmacological measures, which include your diet, which should be low in fat and high in protein. So low in fat and high in protein and carbohydrates. Then the pancreatic enzyme supplementation with meals. correct the malabsorption of fat-soluble vitamins and vitamin B12, micronutrient therapy with methionine, vitamin C and E. Then we have steroids, which should be used only in your autoimmune pancreatitis. Then the medium chain triglycerides in patients with severe fat malabsorption that are directly absorbed by your small intestine without the need of digestion, and reducing the gastric secretions may also help, and if there is diabetes mellitus, we need to treat it. So this is all about your medical management, which has been beautifully explained in this table in your Bailey and Love. Now moving down to the surgical treatment. So if there is an inflammatory mass in your pancreatic head with or without dilated pancreatic duct, we need to do a duodenum preserving head resection, which includes your Berger procedure, Frey procedure and Bernay procedure. So at least remember these names of your surgical procedures. Now if you have your dilated pancreatic duct with more than 6 mm, right, then endoscopic treatment would include your sphincterectomy, lithotripsy, stone extraction and your stricture dilation and stenting, and your surgical therapy would include your Frey procedure or your modified Pustow procedure. Now if there is a small duct disease which is less than 6 mm, then we need to do a V-plasty or a total pancreatectomy with an islet cell autotransplantation. Now in cases of your inflammatory mass in pancreatic head, you may also need to do a Whipple's procedure in some cases. So even if you do not go in the depth of what surgery is what, at least remember your surgery name. So this is all about your chronic pancreatitis.